Hello everyone, this is Krishna from the MASH Guide, and today we are going to have a discussion on anemia. So we are going to do a quick rundown. When we are given a question on anemia, first of all, we should check the mean corpuscular volume, MCV. So normally it is between 100 to 80 to 100. If the MCV is greater than 100, we are dealing with a macrocytic anemia. If it's less than 80, microcytic anemia. So, macrocytic anemia, when we are dealing with, it could be megaloblastic or non-megaloblastic. Now, there is an important thing to understand that as an RBC matures, so from the reticulocyte stage to a mature RBC, it constantly shrinks. So, it is very big to begin with and then it shrinks down in size. Now, very important in this process is the DNA. So, once a red blood cell is mature enough, it has got proper DNA, it becomes small in size. Now, this DNA formation, as we know, requires a lot of enzymatic reactions, B12, cobalamin, which is right, and B9, which is your folate. If there is a deficiency of B12 or B9, it will lead to defective DNA synthesis. Defective DNA synthesis means that the red blood cell never matures and remains in that big state, which is megaloblastic. Or it could be due to defective DNA repair, like in case of Fanconi anemia, where we are not able to repair the DNA strands, and this leads to megaloblastic anemia. When we think of non-megaloblastic, but it is still MCV is greater than 100 femtoliter, but it is non-megaloblastic. So when you think of megaloblastic, think in terms of the DNA of the red blood cell, like in case of B12 and B9 deficiency or defective DNA repair. Non-megaloblastic would be with a liver disease, or how do we get the liver disease? If somebody is using too much alcohol. Then moving on to the next, we'll talk about microcytic anemia. Now, again, if we think of red blood cell, it has got hemoglobin. Hemoglobin has heme and globin chains. Now, heme is the part where we have got iron. So, of course, if there is iron deficiency anemia, you'll have problems with the heme formation and there will be microcytic anemia. Another thing is anemia of chronic disease. In anemia of chronic disease, in our liver, we produce a very important factor called hepcidin. Now, hepcidin, if it binds to ferroportin, once hepcidin binds to ferroportin, it inhibits the release of iron from macrophages, and you are also not going to absorb any iron from your guts, from your GIT. In a patient with anemia of chronic disease, let's say somebody has SLE, or some other debilitating, like let's say some sort of malignancy that has been ongoing. Because of all the inflammation, liver produces excess of this hepcidin, and this hepcidin binds with ferroportin to inhibit iron utilization. So because iron is never released from the macrophages, iron is never absorbed that much from the gut. So this is kind of playing hide and seek with the iron. Do we have iron? Yes. But what do? We trap it inside the macrophages. How do we differentiate then between iron deficiency anemia and your anemia of chronic disease? So if you look at the serum iron level is going to be low in both iron deficiency anemia and anemia of chronic disease. But what about ferritin? Tin. We store biscuits, we store things in a tin box, right? So you can think of this as stored form of iron. So in a patient with iron deficiency anemia, even the stored form is going to deplete. Actually, it is going to deplete even before your serum iron gets depleted. We'll start using from the storage, right? But in iron deficiency anemia, because there is no iron, the ferritin is low. In anemia of chronic disease, on the other hand, the ferritin will be adequate. This is going to be normal because we are just hiding all that iron. We are just hiding the iron. Then what about transferrin? So in iron deficiency anemia, the transferrin is going to increase. Transferrin, you can think of it like a bus to transport all the iron. So transfer in iron deficiency anemia, it will be upregulated. But in anemia of chronic disease, the body knows that the problem is inflammation, the problem is not iron, so transferrin levels remain normal. So this is how we differentiate between the two. Now lead poisoning is a condition. Lead actually inhibits ALA dehydratase in the process of heme synthesis. So anybody with lead poisoning, well, first of all, what would be the overall symptoms? Well, there could be lead lines, there will be encephalopathy, there will be abdominal pain, abdominal colic will be there, then there could be wrist drop in the patient. So lead poisoning, because we inhibit two very crucial enzymes in heme synthesis, leads to microcytic, or you might have heard the term sideroblastic anemia, which can be due to other causes as well, but lead poisoning is one of those. Now globin, as we know, globin chains are defective in thalassemia. There could be alpha thalassemia due to defect on chromosome 16. So you might have seen a picture where they draw these alpha things and they talk about cis and trans. So cis is like on the same chromosome, and trans is like on a separate chromosome if it is lost, right? Then we have got beta thalassemia, which is on chromosome 11. Again, here we hear the term heterozygous, homozygous. We have got beta thalassemia minor and major, and this is the terminology around it. Now, once we have figured out macrocytic and microcytic, we come to a very crucial one, normocytic. So here the MCV is between 80 to 100, which is normal, which is absolutely normal. Now, there are two situations. Either there is hemolysis going on or there is no hemolysis. This is just, it will take some time before it becomes like microcytic. So iron deficiency anemia can be microcytic. At some earlier stages, it may be normocytic. Anemia of chronic disease, similarly, we have seen it can be microcytic. In the earlier phase, it could be normocytic. Then CKD. CKD, we know it can lead to anemia of chronic disease and it can cause normocytic anemia. Aplastic anemia, now this would be a condition where your erythropoietic precursors are affected. And a very easy way to know that we are dealing with aplastic anemia, they can give you like a picture with fat in the bone marrow. Another way is pancytopenia. So you can imagine if the bone marrow is affected, all the cells are going to go down. It won't be just the RBCs that are going down. So there will be aplastic anemia. Now coming to hemolysis. When hemolysis occurs, there will be subtle clues given to you. The reticulocyte count will increase. The bone marrow will try to account for all the red blood cells. So this is my blood vessels. The red blood cells are getting ruptured inside it. So what will the bone marrow do? The bone marrow will upregulate its response. So that will lead to a high reticulocyte count. When red blood cells rupture, they release certain things like LDH. So LDH will be high. Also, when heme will be broken down, how we know heme gets converted into bilirubin. So of course, the liver is going to try to conjugate as much as bilirubin as possible. Now, once it is conjugated, we know it can go into the urine. So urobilinogen in the urine will lead to dark urine. Also, there will be some bilirubin that will be beyond the capacity of the liver to conjugate. So there will be increase in unconjugated bilirubin also. There can also be formation of, because of this excess bilirubin, pigmented gallstones. So because red blood cells ruptured and then we have to process that heme into bilirubin, these things happened. We got urobilinogen and dark urine. We got unconjugated bilirubin rising. We can get pigmented gallstones. We already know LDH ruptured, and we know that by response, bone marrow increases reticulocyte count in hemolytic anemia. Another important thing to note is that once hemolysis happens, we know that there is heme and globin, right? So haptoglobin is something that binds to this. So once it binds to the ruptured component, it decreases. So that is why there is decreased haptoglobin. Okay, now when we think of hemolytic anemia, which is the final category that we are discussing, so that we can focus all our energy here, it can be something external to the red blood cell, or internal to the red blood cell. Internal would mean intrinsic hemolysis. So it could be some sort of membrane defect, like we know in hereditary spherocytosis, where we get spherocytes due to ankyrin and spectrin defects. So these are very fragile, they are shaped like a sphere, and this thing is going to be, MCV is going to be normal, right? So hereditary spherocytosis is going to rupture and cause intrinsic hemolytic normocytic type of anemia. Paroxysmal nocturnal hemoglobinuria, as the name suggests, we don't have DAF, CD55. It's like the same component, and then MERL. If these things are not there, the red blood cells becomes very susceptible to the attack by complement. So complement will come and attack it at night especially, and the red blood cells will undergo hemolysis. So it could be a membrane defect. It could be an enzyme deficiency, like G6PD deficiency leading to oxidative stress, or pyruvate kinase deficiency. We already know there are a lot of hemoglobinopathies that we know on electrophoresis, like sickle cell anemia, hemoglobin C disease. These could be genetic, and it will lead to intrinsic hemolysis. Again, these will be your clues. When we think of extrinsic, it is happening outside the red blood cell. So it could be something related to the vessel, like microangiopathic type of hemolytic anemia. If you think, it is because the vessel is very narrow. Vessel is very narrow. For example, in obs-gynae we study HELP syndrome, right? So hemolysis is a crucial feature. Low platelets is another feature. Elevated enzymes is another feature. So three main things are there: hemolysis, elevated liver enzymes, and low platelets. So this hemolysis, it occurs inside the vessels, inside the small vessels. So we call it microangiopathic. Similarly, DIC, if there is activation of the coagulation cascade, right, and all the coagulation parameters go up, so we know that we are dealing with DIC. Again, this is microangiopathic. And similarly, your TTP HUS. So HUS we see with E. coli O15's NET7, right? So HUS, thrombotic thrombocytopenic purpura. So this is my blood vessel. A thrombus formed inside it because of excess activation of the coagulation cycle. So all the platelets came and stuck to this, and there is formation of this thrombus. So thrombotic thrombocytopenic purpura, and then things start cleaving on this. Things like red blood cells. Red blood cell will come and it will get sheared off. This also leads to formation of schistocytes. So we'll find schistocytes as well on the clues. So we'll find these schistocytes or helmet-like red blood cells. Macroangiopathic would be, if microangiopathic will be, this is my heart and the valves are located. Let's say this is my mitral valve and the mitral valve was prosthetic. The patient had rheumatic heart disease for which they underwent like valve repair, and we had to do a prosthetic heart valve. Or if the patient had aortic stenosis. Now while passing through this narrow opening, if the red blood cell gets sheared, it is going to be your macroangiopathic. It is happening inside the aorta, it's happening in the heart. So these are macroangiopathic because we're dealing with like bigger fish now. So this is overall a quick review of anemia for USMLE. Thank you so much for tuning in with us today. I hope you found this session extremely useful and now have a much better understanding and confidence to tackle this topic. If you're looking for more in-depth guidance and tips, please check out our website, thematchguy.com. It's a platform dedicated to helping med students and also medical graduates. We simplify complex concepts, distill the content for you, and provide personalized support. We are all about supporting and helping you achieve your dream match. So if you're preparing for USMLE or your residency applications, you're in the right place. Thank you so much once again. And until next time, keep working hard, keep learning.